Okay, so we're going to go ahead and finish up with neurocognitive disorders. Now, neurocognitive disorders are going to vary from your neurodevelopmental ones, as neurocognitive disorders are those that are not developmentally related, but instead they are usually developed or occur when an individual declines from a previous level of cognitive ability. So, an individual will have a certain level of cognitive ability, and these, as a result of, again, a variety of diseases which cause dementia, they will decline from that initial ability. So, um, these are going to be acquired instead of being developmental in nature. And just to kind of get started here, there's a variety of diseases, but we will cover just a few of them. But dementia is going to be a group of symptoms. Okay, so the symptoms related to like memory, thinking, problem solving, language, and perception that have declined in ability, and these are going to be caused by these diseases, the most common of which is going to be Alzheimer's disease. There's others as well, vascular dementia, mixed dementia, those with Lewy bodies, and frontotemporal dementia as well. Also, TBIs, substance and medication use, HIV infection, prion disease, Parkinson's, Huntington's, as well. So these underlying conditions or diseases are what cause the symptoms of dementia. So we have what's called major neurocognitive disorder. This is also known as dementia. And it's characterized by a major decline in cognitive functioning that's getting in the way of an individual being able to function in life. And usually it's accompanied by changes in emotional functioning as well as personality, an individual's insight or understanding of their abilities or how they're acting. It might be poor, so they might not notice this. And again, there's different types that exist with different patterns of deficits and underlying causes, as we just explained. There's also mild neurocognitive disorder, and this is going to be a lower level version that involves modest declines from previous functioning, but there isn't as much impairment in an individual's ability to function as there is with major neurocognitive disorders. So these are some of the cognitive domains that are going to be impacted by neurocognitive disorders. And the first one is going to be attention. So an individual may become more easily distracted than they once had been and have trouble paying attention and multitasking. Executive functioning may be impaired, and executive functioning has to do with the ability to organize, plan, and carry out a set of things in an efficient manner. It also includes our ability to self-monitor and control what we do, and to follow through with goals that we have. So some examples of how somebody's executive functioning may be impaired include poor judgment, being disorganized, acting inappropriately in social instances, not being able to make plans for something that might happen later in the day or at a later time, and not understanding how their behavior affect other people around them. This might make it seem like the person is behaving selfishly, especially if their memory is still quite intact. Also, there could be memory impairments. This is going to be the most well-known cognitive change that you'll see in these diseases and amongst the symptoms of dementia. In some circles, dementia is even called forgetfulness. So this is going to be probably the most pronounced symptom that people start to notice, or it starts to affect somebody's ability to function. Also, some perceptual or motor abilities. So this means being able to understand what one sees. It has to do with how like the brain and eyes speak to each other. So somebody might not be able to connect like a hairbrush is for brushing hair just by seeing the object. So they can't connect that what they are seeing has a specific understanding or concept or label. Also, language shifts in three different ways. The first two are yin and yang, and are the yin and yang of language, what are termed expressive and receptive language. So with expressive language, this is one's ability to call up the word like they want to use in a given moment. And when this ability decreases, words that are available may be used rather than the most obvious words. So instead of an elevator, it might be the up, down, up, down, up, down. Again, so instead of looking for the word that actually applies to the situation, the most available word is what is going to be used. Receptive language, on the other hand, is when we hear a word and we know the concept it connects to. So the word fork, it doesn't connect in the brain to the object fork anymore. So these two types of language use do not change equally. Somebody might have large changes in expressive, but no changes in receptive, or vice versa. And then there's also social cognitive declines. And when somebody has dementia, it can shift their social behavior. This can range from perception of others' emotions to decreased inhibition, and there can be less of a filter between thoughts, feelings, and actions. And so they may not, literally censor or filter the things that they do or say. We all have thoughts and feelings that are not socially acceptable, but they're usually fleeting and we don't verbalize them, and we filter them out. But as social cognition possibly declines, the filter starts to basically degenerate and they may act on these flashes of emotion. And the beauty of this is that I guess you always know where somebody stands. There's deep honesty, but and again, people you may know that may not have the filter, that's what you get. But in regard to this, it would be a decline from where they were initially. So somebody that had a very strong filter that wouldn't say or behave in a specific way, now they are, and it's socially unacceptable. Okay, so in regard to major neurocognitive disorder, we talked about, yes, some of the symptoms or things that you might see with it, but for the criteria to be diagnosed with a major neurocognitive disorder, or major or mild, as we'll talk with the specifiers, there has to be some sort of evidence that there is decline from a previous level of performance in at least one of the cognitive domains that we just talked about. And this is going to be based on either the individual who is experiencing it is concerned, maybe a family member, a sibling, somebody in their life has concerned, or a clinician or a doctor has concerned and noticed that there has been a significant decline in cognitive function. So somebody has to have noticed. And then there has to be substantial impairment in cognition. And this is preferably found within neuropsychological testing. So that has to be present. And then with B, the deficits interfere with an individual's ability to function in everyday life. So things, paying bills, managing medications, returning phone calls, making appointments, attending appointments. And the cognitive deficits don't occur in the context of delirium, and they are not better explained like a mental by any other psychological disorder like schizophrenia. Okay, and so that's going to be major neurocognitive disorder, minor neurocognitive disorder, or mild, should say mild. I apologize for that. There's evidence of modest cognitive decline from a previous level of performance in at least one or more cognitive domain, which we talked about. And it's based on either the individual, somebody around them, or a doctor is concerned and has noticed a mild decline. And there has been a somewhat modest impairment in cognitive performance, documented by neuropsychological testing. Now, here's the difference between the mild and major neurocognitive disorders, in that the deficits don't interfere with the individual's capacity for independence. So they're still able to pay bills, but it's starting to take more effort, or they might be using compensatory strategies or accommodations. So they are leaving possibly sticky notes all over the place, or rearranging things in a way that helps them possibly remember things. And again, the cognitive deficits don't happen in the context of delirium, and they're not better explained by any other psychological disorder. So that's the difference between mild and major neurocognitive disorder, in that an individual can still perform functions or actions in life or behaviors in life. But it's starting to require greater effort, whereas in the other, it is definitely causing dysfunction in their life. And then, okay, so these neurocognitive disorders, again, we're looking at the symptoms of dementia. These symptoms of dementia that result in a neurocognitive disorder is going to require a specifier. So we're trying to determine what is the underlying cause of these dementia-related symptoms. And these can be, again, as I've mentioned, due to Alzheimer's disease, which is going to be the most common, frontotemporal degeneration, Lewy bodies disease, vascular disease, traumatic brain injury, substance medication use, HIV infection, prion disease, or Parkinson's disease. So there's going to have to be a specifier that's noted through that. So doctors, clinicians will determine what is the underlying cause of those dementia-like symptoms, and it will be one of those. And then there's also another specifier with or without behavioral disturbances. This would be another thing that would be noted by a clinician. So without behavioral disturbance, this would be if the cognitive disturbance is not accompanied by any clinically significant behavioral disturbance. But with, and this should be able to help delineate between the two, if the cognitive disturbance is accompanied by a clinically significant disturbance, so things like mood disturbances, their moods go up and down, or they're overly agitated or irritable all the time, or they're apathetic in that they just maybe are not as empathetic, or they don't care about things like they used to, or possibly even psychosis. So that would be with or without behavioral disturbances. So some other cognitive deficits that are seen in major neurocognitive disorder. Um, again, so you might see deficits in memory, deterioration of language, echolalia, which is repeating what is heard, palilalia, repeating sounds or words over and over, apraxia, impairment of the ability to execute common actions like waving, agnosia, being unable to recognize objects or people, and again, loss of executive functions, that planning and organizing uh, function that we have in our prefrontal cortex. Okay, so okay, so in regard to this, the prevalence rates. Okay, so with major neurocognitive disorder, I have more here as well. Um, According to DSM-5, it occurs in around 1 to 2% of people at the age of 65. And by the time somebody is age 85, about 1 out of every 3 people have this. In comparison with mild neurocognitive disorder, it's going to be about 2 to 5% of people by the age of 65, and about 5 to 25% of people age 85. So again, you can see that it's very prevalent, especially once one hits 65 and then 85, it's extraordinarily prevalent. There's about 6.2 million people in the US living with Alzheimer's disease, which is going to be the most common major neurocognitive disorder. And in the United States, Alzheimer's disease is the 6th leading cause of death. And in people age 65 and older, it is the 5th leading cause of death. So in regard to this, let me see here. Again, it's going to, all of this information, it's going to vary based upon the specifier. So what is the cause of the dementia-like symptoms? Somebody who has underlying Alzheimer's disease, it may present or progress differently than somebody who has dementia with Lewy bodies. But they're all going to result in these same symptoms. Also, with the risk factors that cause this, again, it's going to vary by the specifier and also the age of onset. Some might happen throughout the lifespan, others might be late in life. For example, like Alzheimer's disease is uncommon before 60 years of age, and it's going to increase very steeply after that. The less common frontotemporal degeneration is going to possibly show an earlier onset, and a progressively smaller fraction as people age. The strongest risk factor for these disorders is going to be age, primarily because age is going to increase the risk of neurodegeneration in the brain, as well as cerebrovascular disease. Um, in regard to this as well, there are genetic ties to it. And so you might see age-related issues as well as other environmental issues, but also there are genetic issues tied to the development of um, these neurocognitive disorders, which can play a role. Okay, so major or mild neurocognitive disorder due to Alzheimer's disease. Okay, so now we're looking at one, and again, we're not going to look at all of these. As far as I know, I think, yes, we're only going to look at Alzheimer's disease. So if you would like, in the DSM-5, you can go ahead and look at the criteria related to other um, underlying etiologies of dementia or neurocognitive disorder, prion disease, HIV infection, Lewy bodies. You're welcome to check that out. But I just want to kind of give you just a basic, a shallow overview of this. So, in order to be diagnosed with, again, major mild neurocognitive disorder as a result of Alzheimer's disease, you have to meet the criteria for major mild neurocognitive disorder, which we just went over. Then there has to be an insidious onset and then a gradual progression of the impairment in at least one or more cognitive domains. For major neurocognitive disorder, though, it has to be at least two domains. So again, it might be memory, it might be attention, it might be the executive functioning. But again, it shows up, and then there's this gradual progression of these symptoms just getting worse and worse and worse. Then criteria are met for either probable or possible Alzheimer's disease as follows. So these criteria are going to have to be met. And so for major neurocognitive disorder, there has to be a probable Alzheimer's disease is diagnosed if either of the following is present. Otherwise, possible Alzheimer's disease should be diagnosed. Okay, so there's evidence of a causative Alzheimer's disease genetic mutation from genetic testing or family history. So if an individual can report like, yes, Alzheimer's disease runs in my family, or somebody gets like a 23andMe. I've actually done this with my sister, and we both have the altered APOE. Basically, there's a mutation on that gene that increases the risk of Alzheimer's disease. As a result of it's run in my family for generations, and we took the test to see if it is present, and it is. And so in regard to that, right off the bat, I would qualify for number one. Okay. Then all three of the following are present. So there has to be evidence of a decline in memory or learning and at least one other cognitive domain. So again, could be memory, and then you might have attention, executive functioning, social cognitive behavior. Then there's a steadily progressive gradual decline without extended plateaus. So this decline, it continues, and there might be a couple of plateaus, but they're not very long. And so people might level out for a while and stay at the stage they're at. But in general, it's going to be progressive. And there's no evidence of a mixed etiology, which could be another reason for a cognitive decline. And so possibly there is another type of specifier that is at play, and it's not just Alzheimer's. So maybe it's an absence of other sort of degenerative disease that could be playing a role in this. Okay, so that is the basis. And then here's the thing. Okay, so this is for major neurocognitive disorder. Somebody has major neurocognitive disorder. This is what we just talked about is what is going to apply. And again, if either of the following, again, either one of these are present. Otherwise, it's possible Alzheimer's disease. Okay, for minor neurocognitive disorder, okay, for probable Alzheimer's disease, it can be diagnosed if there's evidence of a causative Alzheimer's disease genetic mutation, like we talked about. And again, this is if you have minor neurocognitive disorder. And then also it could be possible if it's diagnosed if there's no evidence of this mutation, but there's a decline in memory and learning, and there's this decline in cognition, and there is no evidence of something else possibly causing this. Okay, so those are in play, and then again, the disturbance can't be better explained by another disorder. So again, you have to have that either mild or major neurocognitive disorder diagnosis, and then depending upon which one you have, you are going to have to fulfill these criteria, whether, again, you have this or this. Okay, so let's see here. The progression of Alzheimer's disease, it begins, again, long before symptoms become apparent. This is called preclinical Alzheimer's disease. It's usually identified only in research settings, so nobody's going to notice symptoms during this stage. And other people around you aren't going to notice. And it can last for years or even decades, and your family nor you know that anything's happening. Then what happens is people are going to develop minor cognitive impairments, have mild changes in memory and thinking. And again, it's not going to affect work or relationships. It's just information might be forgotten here and there that should be usually easily remembered, things like appointments, conversations, things like that. And then it's usually diagnosed in the next stage when it becomes clear that to family, doctors, somebody is having trouble with memory, thinking, which is impacting their daily functioning. Maybe they're asking questions over and over, they're having a hard time planning things, their personality shifts, or they're, again, uncharacteristically irritable, have reduced motivation, they have a hard time finding the right words, or they're getting lost and misplacing things. That is outside of the ordinary. And that's usually the point at which it is diagnosed. The next stage involves moderate dementia, and that people start to get more confused and forgetful, and that's when they need help to complete their daily tasks. The next stage, with moderate dementia, again, well, we just talked about that. Forgetting details of personal history, address, phone number, might need help getting dressed, bathing, may lose control of their bladder, also might become paranoid, restless, having outbursts of anger. Then in the last stage, this is going to include severe dementia. They have difficulty with physical movement. They may not have the ability to converse or speak in a lucid manner. They might need total assistance with eating, dressing, going to the bathroom, and they have a difficult time walking without assistance, and muscles may become more rigid and they may lose the ability to swallow. So the rate that this progresses is usually people with Alzheimer's live between 3 and 11 years after diagnosis, but they do have the capacity to survive for 20 years or more. And again, depending upon how early it is caught and diagnosed, that really determines how long somebody can live, especially now since there are a variety of medications and treatments that can prolong individuals' life and really slow down the degradation of parts of the brain, or the tangles. The tangles that you will see happening in the brain with neurons don't happen as quickly because here's the biology of Alzheimer's, in that neurofibrillary tangles happen. This is made of a protein called tau that gets in the way of nutrients and other essential supplies from moving through cells, and that causes the cells to die. Also plaques, these are going to be deposits of beta amyloid, and these are neurotoxic, and they accumulate in the spaces between the cells of the cerebral cortex, hippocampus, amygdala, and other brain structures, which are critical to memory and cognition. And so if that gets in the way, then those types of activities are not going to occur. So you're going to see extensive cell death in the cortex. Again, that is the wrinkly part of our brain, which is going to shrink it and enlarge the ventricles of the brain. And cells are also possibly going to lose their dendrites, which is lose their dendrites or damage the dendrites. And this is, of course, where how cells link to one another, and axons will no longer be able to communicate to attaching dendrites. Thus, we see again the cognitive decline. And so you can see these. Okay, so here's your neurons. We've got our neurons, and you can see the plaques in here. Again, they're all over the place, and they're getting in the way of all the connections. And then inside of the cells, you can see these tangles as well that are going to cause damage. So that is really what is, again, killing cells, getting in the way, killing cells, getting in the way of cells communicating. All right, this is an image of a healthy brain on the left and somebody with advanced Alzheimer's. You can see that there's major shrinkage in, again, all of the cortical areas, just not even there. And the brain with Alzheimer's lost about 25% of its size. So even in regard to brain volume, again, it is extraordinarily small compared to the normal brain as a result of that cortical damage. Again, the causes, we're looking at the APOE gene, like we talked about genetically, and the certain variants of it lead to reduced cortex and hippocampal volume as early as childhood, thus increasing the risk of Alzheimer's later in life. Also, Down syndrome can predispose someone to Alzheimer's disease. And also deficits in neurotransmitters. So if you have deficits in any of these, acetylcholine, norepinephrine, serotonin, somatostatin, and peptide Y, that could also predispose individuals to the development of Alzheimer's disease. Okay, and again, you can see these healthy cells that have all of these connections and talking to one another, whereas Alzheimer's cells, again, they're limited, they're broken off, very few connections. Okay, so let's see here. Okay, so you'll continue. Also, with vascular neurocognitive disorder, this is just an overview here. This is when you're going to see a significant decline in processing speed, inability to pay attention, executive functioning. That's going to affect the blood vessels in the brain. And so this is where cerebral vascular disease comes into play, and that blood supply to areas of the brain is basically blocked. And that's where the damage to brain tissue comes into play. And it can also result in stroke, which is the sudden damage to an area of the brain due to blockage of blood flow or to hemorrhaging. And the severity of the cognitive symptoms and functional decline make it a mild or major neurocognitive disorder because of all of this damage causing the cognitive symptoms that you will see. Also, other neurocognitive disorders and the dementia-like symptoms associated with the following diseases. Okay, so it's not just Alzheimer's or vascular, but also Parkinson's. This is your chronic and progressive movement disorder. Initially causes tremor in one hand, stiffness or slowing of movement. And again, that is the basis for dementia related symptoms as well in your neurocognitive disorder. And also that due to Lewy body disease, this is the one that Bruce Willis has, causes progressive decline in mental abilities. They might have visual hallucinations, changes in alertness and attention. Other effects, there could be Parkinson's related symptoms as well, slow movements, walking difficulties, tremors. HIV is also a precursor to neurocognitive disorders, and that about a third to a half of individuals with HIV will experience the symptoms of at least mild neurocognitive disorder. About 5% will be diagnosed with major neurocognitive disorder due to this infection. Huntington's can cause this as well because brain cells in certain areas of the brain start to break down because of the disease. And as the neurons degenerate, it can lead to emotional disturbances, loss of intellectual abilities, uncontrolled movements, akin to dementia-like symptoms, TBIs, because basically the injuries are going to, again, alter the state of the brain, the structure of the brain, leading to potential dementia-like symptoms. CTEs, again, you're going to see that most commonly in athletes that incur a lot of head trauma during their careers. And we know now this is a progressive neurological disorder that can cause problems with thinking, understanding, communicating, movement issues, impulse control, depression, confusion, irritability. And again, this is usually the result of lots of blows to the head and you see this many years after that occurs. So some treatments for neurocognitive disorder. So we have cholinesterase inhibitors. These can work by boosting levels of cell-to-cell communication. Again, they're going to preserve a medical messenger or a chemical messenger that's depleted in the brain. These are usually the first medicines tried, and most people see moderate improvements. And again, because we're increasing the communicative abilities of the cells. It might improve symptoms related to behavior, like agitation and depression. You might see these cholinesterase inhibitors that include Aricept, Adlarity, Razidine, and Explon. Also, uh, memantine or Namenda. This is going to also work in regard to brain cell communication, slowing the progression of symptoms. It's sometimes used in combination with the cholinesterase inhibitor. There's some rare side effects like dizziness and confusion, but in general, this is used for moderate to severe Alzheimer's. Also, in 2021, the FDA approved aducanumab, Aduum, for treatment of some Alzheimer's. It was a study in people living with early Alzheimer's disease, including those with mild cognitive impairment. And it was approved in the US because it removes amyloid plaques. So again, those plaques, those chunks that we saw getting in the way of the communication of cells, it removes those. But again, how effective it is in slowing cognitive decline has been mixed and coverage is limited, so it's not widely used yet. But there are treatments being studied internationally that do have some very positive potential in the treatment of Alzheimer's as well. Also, Leqembi has shown promises for people with mild Alzheimer's and mild cognitive impairment. And this was approved in 2023. A phase 3 clinical trial found the medicine show cognitive decline in those with early Alzheimer's decreased by 27%. And it works by preventing these plaques from clumping. So it's like an anti-clumping treatment. And it was the largest so far to look at whether clearing clumps of amyloid plaques from the brain can slow the disease, which we can see that it does. Another study is considering how effective this is for people at risk of Alzheimer's disease, including people who have first-degree relatives, such as a parent or sibling with the disease. So this could be something in the future, even for myself, that maybe we can take before symptoms start to occur in order to potentially stave off the decline in cognitive functioning. Okay, so to prevent, antidepressants and anti-anxiety drugs, these help control emotional symptoms, your antipsychotic drugs, hallucinations, delusions, agitation. Again, if these things occur, also behavioral therapies help patients control anger and emotional outbursts. And I know it says prevention, this is still treatment. And activity, this is another one. This is the big one in regard to the prevention of neurocognitive disorder. Physical and mental activity. This is going to reduce the risk of neurocognitive disorders. These up here, these are all treatment. This is prevention down here. This is prevention, as well as being aware of family history and possibly different things through a clinician that one can do in order to stave off neurocognitive disorders. And in regard to treatment, it's important to adapt to the needs of somebody with Alzheimer's, and strengthening routines and habits and cutting down on tasks requiring memory can make life a lot easier. So I'll just go through a couple of these. Keys, wallets, and phones in the same place so they don't get lost. Medications in a secure cabinet. Having somebody with Alzheimer's carrying like a phone that has the location on. Finances on automatic payment. Alarm sensors on doors and windows. Appointments on the same day to create, again, that structure. Calendars. Excessive furniture and clutter and things like that need to be removed. Sturdy handrails. Shoes and slippers are comfortable and provide good traction to prevent slips and falls. A lack of mirrors. Again, depending upon where an individual is at with Alzheimer's, they might find images in the mirrors confusing or scary. An ID bracelet or medical alert, and then keeping photos and other objects with meaning around the house. So that is part of the safe and supportive environment that can be developed for individuals with Alzheimer's disease, and obviously other dementia-related diseases as well. Then, just really quickly, We'll jump to delirium just for a second. And that delirium, okay, this is going to be a little, this is different than your mild and major neurocognitive disorders. This is going to be a disturbance in attention that's accompanied by reduced awareness of the environment. It develops over a short period of time, like hours to days. And again, it's showing a change or a decline from baseline attention and awareness, tends to fluctuate in severity during the course of the day. Again, there's some other cognitive disturbance like memory, language, perception. And the disturbances or an A or C, they're not explained better by anything else. There's an evidence that the disturbance is a direct physiological context or consequence of something else, like substance intoxication or withdrawal, exposure to a toxin, or multiple etiologies. So some of the causes of delirium may be a neurocognitive disorder. This could be the strongest predictor. Intoxication of drugs or the withdrawal, abnormalities in neurotransmitters, electrolyte imbalances, medication side effects, toxic substances. And again, there's maybe a medical condition affecting the level of acetylcholine in the brain as well. So with that, specifically, yeah, again, with delirium, you're looking at a short-term impairment of consciousness in the way that somebody is able to attend and be aware of the environment, which are core features of normal consciousness. So this level of consciousness has declined. And as a result, it's affected those cerebral cortical functions, as well as the cerebral cortex. So yeah, it could result in the reduced ability to direct, focus, sustain, and shift attention as well. You might have to repeat questions to the individual as their attention wanders. The individual might be easily distracted by kind of irrelevant stimuli, and it affects both internal thinking and insight, and making sense of what's happening in the environment as well. And again, it develops over a short period of time, and worsens in the evening and night with external orienting stimuli decreasing because of the darkness. Again, it's usually the cause of some other medical combination as well. Let me see here. The prevalence rate of delirium, it's usually going to be highest among hospitalized older individuals and varies depending upon the unique individual, where they're at, sensitivity of the detection method. So in Finland, there was a study done that indicates the prevalence in the community is pretty low, 1 to 2%. It's in 8 to 17% in older individuals presenting to North American emergency departments. So individuals showing up to the ER, 8 to 17%. Where the delirium often indicates something else that's going on, because there is something physiologically underneath this as well. The prevalence of delirium when individuals are admitted to the hospital is anywhere from 18 to 35%. Estimates of the occurrence of delirium arising during hospitalization range from anywhere from 29 to 64%. Let me see here. 20 to 22% individuals in nursing homes. 88% of individuals with terminal illness at the end of life. So, and again, the majority of individuals, again, minus those, at end of life, will have a full recovery with or without treatment, especially if they're not elderly. But it may progress to things like coma, seizures, or death, especially if it's undetected and whatever is causing it is not treated. It might be it might be associated in long-term follow-up with cognitive decline or major neurocognitive disorder, especially those with pre-existing underlying impairments. Mortality among hospitalized individuals with delirium is high, 38 to 81%. And those individuals with delirium die within 1 year of diagnosis. And again, it's particularly great among those with malignancies and other medical illnesses. And so, yes, they have this. But again, if it's just the delirium, it can be recovered from. But based upon those underlying conditions, that is usually what is going to cause those deaths. Let's see here. It's increased. The chances of developing this is increased if there's functional impairment, pre-existing cognitive impairment, increasing age, illness severity, infection, depression, history of stroke, and history of alcohol use. And then your neurocognitive disorders increase the risk for it as well. Um, Older individuals are very much susceptible to this in comparison to younger individuals. Let's see here. So that is just an overview in general of delirium. So I'm hopeful that this gives you a basic idea of neurocognitive disorders. And I know we didn't go through all of them, but if you are interested, feel free to look at that DSM-5 and check out the rest of the underlying causes of neurocognitive disorders and dementia-like symptoms. Otherwise, I hope everybody has a wonderful day, and we will talk to you soon.